Good afternoon. Welcome to the Real World Perspectives on Poverty Solutions speaker series for our next installment on this beautiful fall day. It's good to see all of you in the room, and we're glad to have you here. We are excited to partner with Michigan Nursing on this talk, and I'd like to begin by introducing Assistant Dean Hala Darwish, Assistant Dean of DEI and Community Culture at Nursing, who will introduce our speaker today.
Thank you, Trevor, for introducing me, and welcome everyone. I'm very pleased to introduce our speaker for this series and for this collaboration between the Poverty Solutions and Michigan Nursing. Dr. Margo Brooks Carthon is a professor of nursing at the University of Pennsylvania. She's the Tyson Family Endowed Chair for Gerontology Nursing, and she's one of the first researchers to show relationship between the quality of nursing care, like staffing and lack of resources, and racial inequities and outcomes like mortality. She co-leads an interdisciplinary group called Thrive to support clinical, social needs of low-income individuals going back home after acute hospital admission. Her research and clinical practice are dedicated to health, equity, and social justice. We are very pleased and honored to have you with us today, and I look forward to your talk. Please, the room is yours.
Good afternoon, everyone. Can you hear me? Wonderful. And so it's such a pleasure to be here. I'm grateful for the opportunity and the invitation. And so as you see from the title, I will be speaking to you today about leveraging the power of empathy to build equitable healthcare systems. And so before I begin, I'd like to begin with a word of gratitude. And so I get the honor to talk to you about Thrive and the work that we've done, but it really is a community that has come together to develop an intervention that really helps to redesign a healthcare system that was failing many people, particularly people with limited economic resources. And so as I speak to you today, I come before you representing community members, representing healthcare providers, grateful for the funding, but all collectively interested and engaged in improving outcomes and healthcare system reform. And so before I begin, I wanted to do a little community icebreaker. So yes, I'm going to talk to you, but you all get a chance to talk to each other. So one of the first things I wanted you to do is just take a moment, and I wanted you to reflect on what some of the challenges that you think of when you think of low-income people, so people with limited financial resources, economically disadvantaged, when they access healthcare. So just take a minute to yourselves. Okay, so you probably have a couple of things that you're thinking of. And so most of you are sitting next to someone. So I want you to share what those challenges are with one another. So just chat with one another. It's okay. This is a community ice building. That means that you get to talk to your neighbor. And so I want you to kind of talk out loud about what are some of the challenges, but I also want you to tell that person who you're thinking of. Who is the low-income person that came to mind who's accessing the healthcare? So I want you to talk about the challenges, and I want you to talk about who you're thinking of. It could be yourself. Maybe you yourself was someone who's low income who had to access healthcare, but it might be some other kind of persona. So take a minute, talk to each other. I'm going to give you 60 seconds. So I got you warmed up, and you're thinking about some of the challenges. So now I want to know if anyone feels brave, any group feels brave, and if you feel comfortable sharing some of the challenges that you identified. What might some of those challenges be for someone who's low income trying to access healthcare?
I had mentioned some of the challenges are language barriers, transportation, and just the lack of education of what the
Okay.
medical system is.
Thank you. So transportation, education, language barriers. So those are really stark challenges. And so those are also some of the people you were thinking about. Thank you. Anybody else had some other challenges? So here and then there.
We talked about worrying about whether insurance would cover things or if you have to pay out of pocket.
Mhm.
And something else I'm thinking about is maybe like not knowing how to use your voice because this person with expertise is standing in front of you and it might be hard to share your expression, feelings, or feel like you're being heard.
So those are other types of communication barriers, maybe some power and some hierarchy in terms of communicating.
Hi. So my colleagues here we had a really good discussion, and some points I wanted to point out echoed was this idea of insurance, but also this idea of like copay and the
Yes.
additional costs that are unseen. So with low-income constituents, having that knowledge of what is the totality of what exactly I'm paying for is very unseen. And in addition to that, some people that have chronic diseases that my colleague was talking about will wait and hold off until they receive the treatment, which can worsen the symptoms and the actual like presence of the disease and make the treatment itself more expensive.
Absolutely. So concerns over copays, which creates kind of a competing demand. And so underinsurance, low insurance, like you all have hit many, many, many of the challenges. And so now I'd like you to talk to each other again, and I would like you to describe what you would do to go about solving these very big, challenging problems. So you have 60 seconds to solve these problems. So go on and talk to each other again. So I want to, these are really big challenges. Okay, have you solved the problems of all that ails people with limited resources accessing healthcare? So Trevor, I want you, raise your hand if you would like to share your big, bold solution. We need to hear them, so raise your hands. We need big, bold solutions. They don't have to be big, they could be small. So your solutions.
People who were in this lecture series last year would have learned from Adam Yenzer and the work that Sevilla did in reducing the state of Michigan application for benefits and free healthcare. I think they reduced it by about 40%, making benefits and health insurance a lot more accessible for a lot of people. And I think that was something we learned in this class that is very applicable.
Very good. Okay, I love it. Any other solutions to the challenges facing people with limited resources, economically disadvantaged? Don't be shy.
Yeah, we talked about completely ratifying the current healthcare system and implementing universal healthcare.
Okay, blow it all up.
Yeah,
Okay.
just completely redesigning. And then also for transportation, thinking about maybe mobile outreach teams that can coordinate with clients to get them to the regular appointments.
Bring care to, redesign healthcare, expand benefits, okay? And one more. These are really great solutions, by the way.
This is kind of like a little niche within reforming the healthcare system, but making like Medicare, Medicaid, I forget which one is for under 65, enrollment automatic so that people don't have to worry about like signing up for all that stuff. If it was automatic, then people might be able to get healthcare more quickly and
Mhm.
have just an easier time with it.
Okay, so widening access to insurance and reducing administrative burden. Did you have a solution friend with the red jacket? I don't want to leave anyone out.
Yeah, actually, I work in healthcare, and one thing that really helps is we use a lot of social workers that hook people up with, or to try to help them with their insurance, and also to assist with like copay cards and to decrease cost for medications.
Okay, love it. So utilizing and leveraging our workforce and providing like direct economic resources. These are amazing solutions. And so I'm excited to talk to you and take you on a journey of how our team did something very similar. So one of the things I didn't hear you talk about is that you would use empathy to solve these problems. No one thought about empathy? Like empathy? It's a superpower, and I too, like you, would not have thought about empathy. That was not on my bingo card. I would not have thought about it as the way to like solve some of the pressing problems, but it is some of the currency that our team used to co-develop a solution that I'm going to talk to you about today. And I'm going to talk to you about the power of empathy paired with principles of equity and how they served as a catalyst for our team as we developed an evidence-based clinical innovation or intervention that focuses on people who are Medicaid insured. So by definition, they're economically disadvantaged. They're leaving the hospital with multiple chronic conditions and social needs. And during that transition, we provide intensive case management and support for 30 days. Our goal is to address many of the social determinants that you all mentioned, like challenges with transportation and copays and housing instability. And we do that within the confines of an interdisciplinary team and as a supplement to home care. So I want to share a video with you that describes Thrive, and then I'm going to walk you through the steps we use to employ empathy. Okay. So that's a little bit about Thrive. The Alex and Hillman Foundation also wanted to highlight nurse innovators, which is why you see a lot of that in the discussion. But one thing that comes to mind when I think about our development of Thrive is that I never saw myself as someone doing innovation or intervention. I was a clinician, I was a researcher. And what I saw in clinical practice as a nurse practitioner helped me see that people who did not have sufficient resources did not do well. They had a harder time getting medication, they had a harder time even getting to our office. And even if they had medical transportation, sometimes they have to sit and wait for hours to get picked up to get back home. And so it never seemed to work for them. And that is really what inspired me to go into doctoral and research, is to think about how we could create a healthcare system that works for all. But it was years of doing this kind of work where I'd been looking at health disparities and looking at healthcare systems and evaluating the ways in which healthcare professionals could be active in working to improve the outcomes of individuals, that I was really becoming more and more frustrated because I wasn't seeing any movement. The needle wasn't moving. So yes, I was researching and getting funded and writing papers, but I wanted to work more directly with healthcare systems, working with healthcare system leaders and clinicians and community members to think about how can we actively move and how can we create change. And that's when I was introduced to human-centered design, innovation, and empathy, which is the first phase of this whole human-centered design process. One of the things I always point out when I talk about the power of empathy is that it's the first phase of the human-centered design, but for us, it drove culture, and it was something that we employ throughout every step. And so when we think about the phases of human-centered design, they begin with empathy and discovery and understanding the context and the problem, and then moving on to define who you'd like to focus on, and then developing and prototyping an intervention and then delivering it oftentimes rapidly and then to scale. And so for the sake of time, I won't be able to talk about quite all of those things in depth, but the purpose of spending and kind of sitting in empathy is because I think because of what we did early on, which was really fueling the work that we did in empathy, it really helped to create an intervention that's been very successful. But a lot of that time and effort and energy went into this first phase. And so John Kolko has a book, and some of you may have heard of it, called Well Designed. And he says you need to deeply understand customers, and we can think in healthcare of consumers or patients. We need to think about their needs and feelings, and this understanding must be reflected in the product. And so one of the things when I think about the video that you all saw, it represents kind of the heartbeat of Thrive, because we really care deeply. But it also represents multiple perspectives. And you heard me say, well, one of the things that was a game changer is when we talked to physicians, right? So I asked you all from a very specific perspective, tell me what it's like if you access healthcare as someone who has limited financial resources. I didn't say, well, pretend that you're a healthcare provider, and what is it like for you to provide care? What is it like for you as a healthcare system leader to provide care? What is it like for healthcare leaders when the majority of your patients have limited incomes? And I bet you that each of the answers, depending on who I'm speaking to, would be different because your perspective is different. The empathy process requires us to ask the questions, not just from the perspective of the person who's low income, but from the perspectives of the system that we hope to redesign. So that's why here, when we say customer, we could also say customers, because in the end, when you're redesigning healthcare, the people who are going to be affected are clinicians potentially, because you're changing their workflow. That's the redesign. If we think that healthcare is designed for people who are commercially insured, high literate and native English speakers, then to redesign it, we have to work with healthcare systems as well. And so you'll see the ways in which that played out and how empathy pushed us to really think collectively about who the end users would be. And these were some of the end users, right? So I went on this empathy journey and I did not go alone, which is important because the process of innovation and co-development should include community, it should include partners, and it should include people that don't look like you. And so there are people here. The co-lead on this project was Dr. Kendall Williams, which was perfect because he was a hospitalist. He is a hospitalist. And he and I co-led this work group. LDI stands for the Leonard Davis Institute for Healthcare Economics, and we were provided with $10,000. So, an embarrassment of riches to come together as a work group to solve this really pernicious problem of how do we improve care for socially complex patients who are hospitalized. So what you see here are people from the community health workers, social workers, researchers, nurses, physicians, all coming together once a week for over a year to think about how we could bring together solutions. And that began with understanding. So our work group goals were to understand the healthcare challenges that patients with complex social needs face during their hospitalization transition. So that transition from the hospital to going home. We wanted to evaluate the resources in the healthcare system that were already in place. We don't want to duplicate. And we wanted to co-develop a solution or set of solutions that would improve these post-hospitalization outcomes. So these are our work group goals. We recognize, everyone at that table or in that group recognized that there was a problem and that our patients in this particular hospital, and so this was set, we began this work in 2018 at Penn Presbyterian Medical Center. Penn Presby is a level 3 trauma center in West Philly. And this particular area of West Philly was designated during the Obama administration as a promise zone. And so the paradox in this is that in this specific area of West Philly, there's a high poverty rate, a lot of home vacancies at the time. and a really low attainment when you look at kind of baccalaureate. At the same time, it's a promise zone. And so I always say that within areas of Philadelphia, there are centuries of Black families who've lived in these areas. So there's like pockets of resilience, family, community connection. So the promise in the promise zone is that despite the economic disadvantage, that there is a thread of resiliency that lends itself to opportunity. And so this is kind of the understanding that we needed to take as we were taking our deeper dive. So we knew about the transportations. We knew we needed to sit with what those challenges looked like once they left the hospital. One of the things that we needed to couple, so I'm an equity researcher, so I wasn't an innovator, but I've taken a long time to think about health inequity and recognizing that health inequities don't just appear, right? Like they are unjust differences that are informed by structural, marginalizing structural conditions, often rooted in racism and discrimination. And so the challenges that we were seeing among patients at Presby did not just occur, and they didn't have to occur, right? Like these aren't things that are absolutes. But we recognize that within the healthcare system, the way that people with limited economic resources are regarded and spoken about is openly biased, right? And so for people who come back to the hospital repeatedly for readmissions or who repeatedly hit the ED, they're called frequent flyers. They're called bounce backs. They're called super utilizers. But they don't talk about that. They don't talk about every patient population that way. So that very specific way that they regard patients, it only happens to certain people. And so we wanted to call that out, that language that is so pervasive and so culturally, it wouldn't even be inappropriate if you were doing rounds and you heard someone referred to in this way. But your VIPs would not be spoken about that way. And I promise you there are VIPs who receive care in hospitals who are not called bounce backs and frequent flyers and super utilizers. So we gotta like call a thing, and that was really important early on. Or we would just start to blame the people, right? Like, well, they're not taking their medicine and what's wrong with them? And we heard plenty of that. And so it was important for us to ground ourselves. Like, we got to look at the system because the system is fragmented and it's poorly coordinated. And that means we got to look at us, right? We got to look at healthcare providers. And that was a really important ingredient. So Dan and Teo in 2020, they outline a bunch of ways in which we should be thinking about approaches to empathy. And they offer more than these four, but I think of them as really important. And one of them is abandoning ego and adopting humility. The other is listening and observing, and finally caring. And so you might assume, well, you're talking about healthcare, don't people care? But I just showed you the other slide, and that tells you that implicitly, maybe they don't care. Maybe they expect these folks, maybe they blame them. The other thing is abandoning ego. And I think that's really important because I came at this work as a clinician and as a researcher. So I kind of came thinking I knew what the solution is. Like, I've done this work. And if only healthcare systems would do this, then we would have better outcomes. And so I was mentored in this process of empathy and innovation. And the mentor at the time, his name is David Ash, said, well, you can't come to the problem with the solution in hand. That work that you've done is your bookends. And now you need to fill in the information that you need to come to a solution. So the work that I'm talking about is not the bookends, it's the stuff in between, okay? So that's where empathy guided us. But it also said, oh, okay, well, this is ego. And I have to like put that to the side because I actually think like, well, I've been a clinician, I've seen this. I grew up in a low-income home, but it's not about me. And so that was one of the first things that I had to kind of put to the side. The other thing is listening. I'm gonna talk about this a little bit more, but this was really important because, you know, we're kind of in a society where it's kind of an echo chamber. We listen to people who agree with us. We listen to people who kind of confirm our own biases. This is a different type of listening. This is listening from multiple vantage points, and it's listening to people that you disagree with. So that's a different kind of listening that empathy requires. Observing is sitting in, right? Just sitting in. And maybe not changing, not redirecting, just being. And that is a certain superpower too. And obviously caring, deeply caring, and caring enough to, you know, try to improve change. So in this empathy phase, again, we spent many, many hours, and some of the action tools that we used during this phase included interviews, observations, and shadowing. So I'm going to talk a little bit about those processes and the outcomes. It was during this empathy phase that we met Andre, and Andre had had a hospitalization and a discharge to home, and we met him in his home. We've changed Andre's name and his photo for privacy, but Andre lived in a one-bedroom apartment. And so I hesitate to say bedroom. He lived in a one room. So the one room was his bedroom. The one room was his living space. He shared a bathroom with other people in the home who shared this one bathroom. So it was more like a boarding home. And he had been hospitalized for an abdominal surgery, and he had a colostomy bag. This was a new surgical apparatus that he left the home with. And he was so disgusted by it that he would not clean out the feces. Instead, he would change the bag. Well, as you might know about insurance, insurance doesn't give you 30 bags. And what we knew is that he was going to run out early, okay? And so we asked Andre, you know, when are you going to go back to see your surgeon? And he had an appointment, but the surgeon is in, you know, Old City, which is probably, compared to where he lived in West Philly, on SEPTA, which is our public transportation, would have taken him probably an hour and a half because he was going to have to transfer to get there. And Andre looked too weak to walk to the local corner store, much less transverse to go see his surgeon. So yes, he did have an appointment, but whether he would make it or not was in question. So we already knew that he was not taking care of the apparatus as he was supposed to because he was changing it. Post-discharge was questionable. We asked about his diet. He said it was mostly eggs and spaghetti. We asked, like, well, how much are you drinking and staying hydrated? He was like, I drink like 2 cups of water a day. We said, well, you know, we're concerned that you're going to run out of your equipment for your colostomy early. And he said, it's fine. I'll just go to the ED. They'll give me more. And we said, well, do you have a primary care provider? He said, I wasn't sick before I got to the hospital. So no, I've never had a need. And so we were just like, wow, this is this young man who has not been set up for success. And as we did interviews with patients who were like Andre, we came across this kind of over and over and over. So you might assume that the healthcare system has some processes to assess and address the needs like Andre, but you would be wrong. So we did focus groups of nurses and we said, hey, nurses across this really big, wonderful hospital, it's a magnet hospital. Tell us about how you're able to address the needs of patients who have considerable social needs. And they told us, well, we don't have time for that. Like, we have to medically stabilize people. We don't have time because we're doing all these other things, like administrative things and charting. And, you know, sometimes we're lucky, really lucky, if they understand their discharge. We have to run through it. Patients told us, people, you know, they just run through it real quick and you got to figure it out when you go home. When we asked nurses from unit to unit what they did, we would get, if we asked 19 people, we get 19 different answers, right? So we know when you have that kind of variation in practice in home care, or excuse me, in healthcare, that kind of variation can lead to poor outcomes. There really was not at the time, and again, this is 2018, and I imagine some of this may have changed now, that social risk factors were not uniformly collected in the hospital. So we use electronic health records, maybe Epic has some social screens. Who did them? What they did with the information was just kind of a big mystery. And when we talk to them about the communication between, let's say, a hospital and primary care, a hospital or home care, like, what's that communication loop look like? It was basically non-existent. So there are just so many ways that people like Andre and others can fall through the cracks. I just named 5, but there are just myriad, just ways that people fall through the crack. And it really helped us see that, you know, systematically there were some opportunities. And so some nurses told us, well, I might give them some extra socks or send them home with some extra sandwiches. That was like their solution. But they even said that that's a Band-Aid if there ever was one. So they recognize that they're unable to address all of these. And I told you about how they said, you're lucky if they understand their discharge. And so, um, the way we developed Thrive during this process is we would meet as a group all together in a conference room at Presby once a week, and we would talk about what we were learning. And this, like the myriad of challenges that we were hearing, I had this person who's kind of like experiencing all of this under a dark cloud. But one of the things that we learned in the process of empathy is that this is hard work, right? Like this is hard work for the people who are in the room trying to come up with solutions. I don't want to make empathy sound like, it was like holding hands, singing Kumbaya, and we were just like happily moving through this process. It was taxing, it was emotionally draining because we cared. Remember, like one of the things is you got to care, and we did. But we were wondering, like, how do we wrap our arms around all of this? Because it's so much. Like, there's inadequate supplies, there's no working electricity, there's no cell phones, there's no primary care, there's unsafe housing. Like Andre lived in an unsafe house. Like where he lived, there were people who were actively using drugs. Like there was really, like, going into the home was a concern, much less handling his new chronic health condition. And this is everything that's going on. And so we're just like, well, where do we even begin to start? So one of the lessons we learned is empathy is really, it's hard. It's a gut punch. The other thing we learned is you're passionate. We were passionate. Everyone was not passionate about the work we were undertaking. And so even though you're feeling all empathetic, it doesn't mean that everyone is like, yes, please get us. We want to know about all the social needs, because actually they weren't. We talked to a lot of people who were like, well, do we really want to open Pandora's box? Well, if we start asking them about their electricity, won't they just stay in the hospital longer? Which, by the way, folks, is not the goal. Well, won't it demoralize clinicians and physicians to ask about all these problems that we don't have solutions for? Well, you know what? We can just call social work or call somebody. And so one of the things about empathy is that you may or may not feel supported. And so how do you deal with that along the way? For us, it kind of set up a certain resolve and a fire in our bellies. But at the same time, in being honest about this work, I just want to let you know that it may not be all roses and sunshine. The other thing that I think is important to understand about empathy, and I also felt like this was a little ego check as well, because there's so many problems and we didn't always know how to wrap our hands around them. This particular quote by Octavia Butler, she's deceased now, and she's a Black author and futurist, and she says, there's no single answer. So I asked you all, like, what would you do? That was a trick question. There is no single answer that will solve all our future problems. There is no magic bullet. Instead, there are thousands of answers to be. You can be one of them if you choose to be. And I love that, right? So that means all of our solutions are important. And it also meant that we didn't have to solve everything to be impactful. We don't solve everything with Thrive, nor could we, because you saw the enormity, but we could still be powerful and impactful. And that's what empathy taught us, right? It taught us that we still could be powerful, even when people didn't agree, even when the problems felt enormous. And this is what we found through the process. This also forced us, which is kind of the second kind of stage of the innovation design process, we had to define. Because when you're in a safety net hospital, there are so many challenges. You really have to focus on who will you deliver this intervention to? Will it be to everyone, or will you have to make some serious choices? And so we used some discharge claims data, and we used some machine learning analytic approaches to see who was most at risk for experiencing a poor outcome. And what we found is that while people who were insured by Medicaid are 24% of the admissions, they represented 45% of 30-day readmissions and 64% of multiple readmissions over a 3-month. We also recognized for people who were Medicaid insured that very few, in fact, only 1 out of 5 received a home care referral. had very, very low percentages of follow-up to primary care. So 22% would go on to see a primary care. Less than half would see specialist follow-up. And we know that the lack of post-discharge follow-up is very much linked to unfavorable discharge outcomes. We already shared that there was no one that was really focused on health-related social needs, although we know that these are drivers to poor health outcomes. And we knew that the communication and coordination was tenuous at best. So focusing on people who are Medicaid uninsured is important. And there are a lot of citizens in the US who are covered by Medicaid, 80 million, 1 in 4. And so that's a lot of our neighbors, that's a lot of people who are accessing healthcare who are at risk for a poor outcome. And we also recognize that disproportionately, many of the people who are enrolled in Medicaid are people of color. In Philadelphia, which has at least 1.5 million residents, 21% of Philadelphia residents are Medicaid insured. So what we were seeing in our small microcosm is actually something that has national and local implications. What we understood, and this is a study that LDI did in 2015, so this was, shortly before we started this work, is that there were areas in the city that had very low rates of primary care availability. And so one of those areas is, if you see that's left of Central, is West Philly. And so we're right there in one of those red zones where there is a lack. And so there would be long waits for primary care and specialty care in these areas. And so that really set us up to think about what we would choose to address with Thrive. And so as you heard, Thrive provides coordination and intensive case management, but it begins in the hospital. And it begins by nurse managers who are able to identify people who are Medicaid insured. We built into Epic a flag, so they don't have to go in and dig and figure out who's on Medicaid. We have built a flag. It is a part of their workflow. They can see a little check and they say, this person's eligible. And so now that we know they're eligible for home care, they can offer it to patients during their admission, which, remember, that wasn't happening. Most people weren't being offered home care. And because now they're getting home care nurses recognize someone is on the Thrive pathway, they're in the home within a few days, and they're right away providing screening, health education, and the physician or the team of physicians and advanced practice providers in the hospital who were providing care during the admission remain available for 30 days after discharge. And so one of the things that happens is that if the home care nurse has a question now, they can ask the person or persons who were directly involved in care. And so that's not the way healthcare typically goes. And so right away, we've created a feedback loop. So let's say the person is diabetic, but doesn't have a glucometer and doesn't have a primary care provider. Now they can go back and say, hey, can you write an order? Can you write a script for a glucometer? Because we want to be able to help this person manage their diabetes in the home. Our team provides weekly case management calls. And so once a week for all of the hospitals we're in, we provide a 1-hour discussion for anyone who's receiving Thrive services. And that interdisciplinary meeting includes people from the hospital, people from the community, people from social work, people from home care, us. And we're all talking about every single person and making sure that people are getting the care they need. And this approach to post-discharge care, again, is not typically what happens. It certainly wasn't happening when we started Thrive. And so we were curious, what are we seeing in the way of discharge outcomes? And so we evaluated our first year of Thrive, and we were able to significantly reduce readmissions and ED utilization. And after that first year, I guess the average outcome for admissions was about 14%. And on average, it's even lower as we've moved forward. On average, we are addressing 3 to 4 social needs for all Thrive participants, and most frequently around medical transportation. So I know you all mentioned that as a challenge. Durable medical equipment, helping people apply for affordable housing, and helping to place referrals to social services, behavioral health, substance use services, and community health workers. We interview and talk regularly with people who are receiving Thrive. And one person said, well, I felt prepared to leave the hospital. The nurses were great. I was very satisfied. I'm not a person that depends on everybody, but with Thrive, I felt seen, I felt valued, and I felt heard. I promise you, this is not the way people with Medicaid experience healthcare. And so to hear this, it has really fueled us, because that is exactly how we want people to feel when we're in those interdisciplinary meetings. If you hear the humanity through which we discuss everyone on that pathway, it is purposeful and is with intent that that be the outcome. So one of the final lessons that we've learned about empathy and infusing empathy and equity is the importance of community stakeholders and the community being accountable to them and them having a voice. Because remember, a lot of Thrive is really geared to health system redesign, but it's so important that the people at the table, so we have a community advisory board and we meet probably every month or every 2 months to discuss with them where we're going with Thrive and how we're doing. And one of the things that they shared with us early in our work is, well, Margo, it's great that you all are redesigning healthcare, but you all need to make sure you bring this back to the community, because communities need this education. They need this information. They need to be empowered. They need to know what to do when they go to a hospital. They need to know what services are available. And at first I thought, well, if we're at these health centers, what if they're asking about Thrive and they're going to a hospital where Thrive services aren't available? So I was really concerned about that. And they said, well, it doesn't matter, right? Like, they still need the information. It empowers them. They can ask for home care when they didn't even know it was available to them. And so what we've done is we go to health fairs and we provide information about, like, what should you do? When should you go to see a follow-up provider? What should you say if they say, well, yes, we can see you, but it won't be for 3 months? So these are all the things that in health fairs in communities, whether they come to one of the hospitals where we're servicing or one of the hospitals where we're not, they still are informed, right? Because they're in the untimely or unfortunate time that they're hospitalized or their caregivers, now they have information that they may not have had before. And so finally, we are growing. And so I shared with you data about when we initially started Thrive, which started in April of 2019. And we were moving right along with our basically kind of a QI project. Can this thing work? And then in March 2020, our lives were turned upside down. And we had to ask ourselves, will we continue? And then we had to tell ourselves, how can we not? Because the very community that we know has the most challenges is the community that is going to be faced with daunting challenges during COVID. So what we did is we pivoted, like most. And so instead of meeting once a week at Presby for our calls, we went to a virtual model, which has continued to this day and has really been helpful in bringing even more folks from the interdisciplinary teams into the space. We've also grown. So remember, I said we started with this $10,000 of seed, but we've been able to gain research dollars from the Rita and Alex Hillman Foundation and ARC to expand Thrive to 2 additional hospitals, to adapt Thrive, which is what we're doing currently, to ensure that people with serious mental illness and Medicaid are also able to access much needed services. And so we're really excited about the possibilities. Thrive was acknowledged by the American Academy of Nursing as an edge runner. And so we're really excited about that due to the work that it's doing to advance health equity. And we're excited about scale, and we have lots of questions about sustainability. But more importantly, we are thrilled with the opportunity to serve and serve better. And so it's been a pleasure sharing Thrive with you, and I'm happy to take any questions.
It was my birthday yesterday, and so I'm going to take the first question for myself. So my
Prerogative.
birthday gift to
Happy
myself,
birthday.
'cause I've got the microphone. So when you had your little guy up on the screen, and you were talking about compassion fatigue, which I think is something that a lot of people face in engaging this work. One of the things that it made me wonder about is how the kind of design process kind of relates to that. So Tom mentioned that we've studied that in this course at a couple of different points. And one of the things that I've always felt when I've encountered design is that it's a very optimistic process. It doesn't necessarily worry about the IRB or a kind of study setup. It asks questions about the problem, asks questions about the situation, and is very optimistic that it's going to get to a solution. And that can contrast, I think, especially with a bunch of other social science approaches. And so I'm interested if that optimism kind of bleeds into the compassion fatigue in your kind of experience. How do you relate those two to each other?
I think that's a good question, which is why I brought up the part about this being heavy work.
Yeah.
But I also want to think about this idea of the antidote to compassion fatigue. So one of the things that I've seen in nursing in particular and in healthcare is we're facing a burnout crisis. And we're facing a lot of moral distress. And as someone who's in a school of nursing for many years, I taught undergrad nursing students about what nursing was all about. And one of the things that drew them to nursing is they wanted to help. They wanted to create deep connection. They wanted to be able to spend time with patients. I imagine that's the same in social work. But then you get into practice and you're not making deep connections. You are running. You are running. You can barely take a break, much less have a deep connection. And that's morally distressing. It is morally distressing to go into a profession where you seek to engage, where you see problems all the time that you do not have the resources to address. One of the things that I feel like this has done is that we've seen so much eager interest in Thrive because it hits providers exactly where they want to be. Like they know this is important. Most of the people who are working are like volunteering, but it's a passion point because they realize like, this is why I came into healthcare. And so as much as it was hard work, it was fulfilling. As we think about sustainability, we have to ask ourselves, like, how do you ask people to do something that might be over and above? Now, with our grants, we're able to give some professional incentives, but it's not $1 million, right? Like it's a couple of $1,000s to kind of, they can go to a conference or something of the like. But even that like acknowledges the fact that they're giving of themselves. But I felt more and more, and people have asked all the time, like, how do you get the hospitalists to like do this? It's because we're natural problem solvers, and every single day to work with a family, to work with a patient, to see them discharged, but then to come back in a week, that's demoralizing. That's compassion, like that's the fatigue where you're just like, what in the world? But it's because you're only scratching the surface. And with Thrive, we get a chance to go deep, and that is what they believe in because they know that it's the model of care we should be aspiring toward.
Thank you. What other questions do we have today?
Thank you. So I'm from Baltimore. So
Oh, did I tell you I was from Baltimore too?
yeah,
Did I
didn't
mention
know.
that? Okay, go on.
And a lot of I'm sure if you're familiar with the black butterfly, the idea that we have low income constituents, and they're kind of segmented in a very specific way. And what I wanted to ask in regards to my question is how do we maintain an empathetic vision of healthcare services in an environment that patients live in? Because in the black butterfly, we see that many of the low income patients, the housing itself has lead paint. And so then you see that the low income constituents are at higher risk for chronic disease. So even if you serve them in a hospital, then you return them right back to where they're living in. So then how do you maintain this vision and prevent the resurfacing and recirculation of the same health issue that prompted them to go and engage with the healthcare system in the first place?
That is the $1 million question. So as you saw from the slide with all the raindrops falling, like this problem is deep, and we are solving for one part of the equation. One of the things I say about Thrive, though, is what Thrive is now shouldn't be what it looks like 5 years from now. Like that's why we saw the challenge during COVID for people who had serious mental illness. We were like, we have to adapt this because this is working. Are we assuring ourselves that it meets the needs? And so I think that we have to continue to innovate around this. model and others to think about those structural determinants which you're speaking about, which are really important. And it's really trying to fund them. Like, I worked for some time trying to get funding with someone in architectural design who wanted to think about, so a lot of the homes in West Philly and actually Baltimore as well are like, they're older homes and they're not fit for people who have chronic illness. Like, they need to be retrofitted. And so he is an architect with also an OT background. And so we wanted to take people who were receiving Thrive, but also the prescription would also be fix the home, right? Like, do things to make sure that they could safely ambulate, shower, do the things they wanted to do in their lives. But getting funding for any of these ideas is really, really challenging. And I think that that's the perennial question. We are not short of problems or really solutions. Like, I think that we have a lot of patients who are diabetic, and I want to do healthy food. Like, healthy food is medicine, and the food in these neighborhoods are crap. And so how do we get healthy food to people to help manage chronic illness? And so just trying to work with community-based institutions and trying to procure resources, like, that's the lifeblood. And I think that we have to be innovative in those partnerships and like how to do the work. But I'm not under the delusion that this is going to solve everything or that this should be the end all to be all. I really am looking to think about how do we continue like to innovate so that 5 years from now, Thrive, I come back and I'm like, whoa, you all don't even recognize what I showed you because this is what we've done to expand, because the problems that we need to address are deep-seated, historical, and they require kind of like this fresh and thoughtful perspective. So thank you for your question because it's right on.
Hi, I interned at one of the area agencies on aging in for my internship. And so Michigan, thank goodness, expanded on the Older Americans Act to try to help. But the unfortunate thing is there's still not enough money, and the waiting lists are so long for especially people that are on waiver with lower incomes to get the kind of care that they need in their home. So what do you see that as being a problem? And getting home health care workers is near impossible because of the rate of pay they make for what the work that they're doing. And I know in Metro Detroit, there's a huge issue. Even when people are in the program, they can't get a home health care worker in. So what are your ideas about combating that?
Oh, wow. This is such a great question. So I don't know if this is something that's occurring here in Michigan, but in Philadelphia, we have paid caregivers, which are family members who are essentially working as home health aides. I think that this has been one of the workarounds from a policy perspective to have more support in the home. Now, I will say, working in this space, the quality of what that care is in the home can be less than desired, though I understand it because it's actually an income stream, right? So it's an income stream for the family or for the individual caregiver. There are some risks sometimes. People are concerned about getting extra home care hours, even if they need it, because it may decrease the amount of paid caregiver hours that they're getting, though said paid caregiver hours may or may not be actually supportive of the chronic conditions they have. And so I feel like this is one of those policy solutions that we need to kind of deal with. And I understand the impulse, and I understand the attraction to paid caregivers because there's so much uncompensated care among family members. They're doing the burden of the work and they're uncompensated. And we have a shortage of home health care workers. And then we also have a shortage of affordable housing. So I said we try to help people fill out the application, but people can sit on those waiting lists for years and years and years. So when I think about sustainability of Thrive and other programs, I really am more and more concerned, only because I think that there is a disconnect between the policymakers and the people who are on the ground. There is a lot of work, particularly for dual eligibles, for example, and trying to coordinate their care across 2 different insurances. And from what I've heard, that mission to coordinate across those two healthcare services and to even have care, managers is just not working for most patients. And then for solutions like Thrive to continue, they really are running in a way that they're not being directly reimbursed. And so we're asking healthcare systems to continue them once the research dollars pull away, and they're not able to bill necessarily for some of the things that we're doing. So I really feel like this is an issue that demands policy advocacy, because that is where the rubber meets the road in terms of reimbursement. And that's the work that, we've been like really, really hunkered down, building the thing and evaluating the thing. But in the end, we need to like push up to upstream and really think about policy reimbursement and working with insurers, because that's where kind of like in the end, we'll be able to sustain some of these models of care. And it's where these policy solutions are coming from that, think about paid caregivers. So I'm not saying it's a wrong-sided solution for paid caregivers. I'm just saying what I see on the ground is that it might be falling short of some of their goals.
Thank you, Margo. This was a fantastic talk.
Thank you,
very
Helen.
much. I have a question about empathy again and Thrive, and in relation to our education and nursing. So I want to know your thoughts about this. A twofold question. First, can we teach empathy? And how can we integrate a lot of the Thrive in our curriculums, whether undergraduate or graduate?
Oh, I love
Thought
that.
about that?
I love that question. One, can you teach empathy? So I believe yes, right? I told you empathy wasn't on my bingo card. I'm a nurse, so I figured I'm like as empathetic as most, but I didn't think of it as the way I would fuel my practice or my research or create culture. And I think it can be a skill, just like we teach nurses and probably social workers and others, kind of the skill of reflection, right? And have being a reflective practice. I think empathy is one needing to define what it is and what it's not. So it's not sympathy and feeling sorry for your patients, which is kind of like more about you, like how you feel. Some of you might have seen, there's this little short, and you should look it up. It's by Brene Brown, and she talks about the difference between sympathy and empathy. And sympathy is when like someone falls in the hole, and if you're sympathetic, you look down and you say, oh, it sure looks dark down there. It sure looks cold. Do you need a sandwich? That's what sympathy looks like. But empathy is like, I come down on the hole with you, right? And I hold space with you and I try to help you climb up, but not just, say how bad it makes me feel for you to feel down deep in the hole. So I think that that's important, right? Because I don't think that we have operationalized empathy for clinicians or researchers, or it feels kind of squishy and it doesn't feel like something that's a tool or a strategy. And that's what I appreciated about this process, is that it's logical, it's strategic, it requires something of you. It's not sunny, sunshine and rainbows. And clinical practice isn't sunshine and rainbows, right? It is challenging. And I do think that in a more challenging and complex clinical environment, this is something that's important, because they're going to face a lot. And I think that there's a lot of disillusionment, because I know the way I taught nursing. I taught it as something that it's filled with passion and opportunity and optimism. I was teaching first-year nursing students. So of course, they come with passion and optimism. I elude it back because I love the profession. The reality, you think about nursing students who graduated, you think about social work students who graduated in 2020, right? What was that like? And so I think empathy is important. The highs and the lows of the experience, the weight of it. And we need to be more kind of intellectually honest about what it is. And I know if I had to go back and teach that class again, part of what I was doing was trying to disrupt some of the kind of like narrative about what nurses are, like nurses are angels and all of that, but not so much saying like, this is hard work. But empathy can be a tool that you use, and not because you feel or you've been through everything, not because you grew up in East Baltimore. You might have grown up with affluence, but you can still carry this as a tool. So I absolutely think we can. The question about Thrive and teaching it or teaching other programs like it is kind of equity infused into innovation is one that I've been thinking more and more about. because I do think about how do we develop these scholars, these practitioners, right? Like we are we are a hands-on profession. And so how can we use this? How can we train people in the school of thinking and let them be like ambassadors of this kind of work? I actually think is like, we got to talk about it because that's the thing I'd like to develop. I'd like more students to be trained practitioners in thinking about our schools, broadly healthcare professions, because this is interdisciplinary. The picture I showed you had social workers, physicians, and how can this work be something that fuels the learning environment? I think, just imagine how transformative that would be. And so I'm happy to think with you about what that could look like, because that excites me. Thank you for that question.
Thank you. So my background and experience has been in health equity at a medical legal partnership in Chicago. And so my question for you is, have you explored involving lawyers in that interdisciplinary team? And if you have, what barriers might there be?
I haven't. I want to ask you the question. If you could, if we could, how could we integrate lawyers into our model? I'm really eager to think about that with you. So if you have some thinking, would that be in the policy space? Would that be for people who are facing kind of legal challenges? But I'm eager and I'm open.
Yeah, so my team was at Loyola University Chicago. So we had providers in Loyola's healthcare system refer clients sort of like in these nursing, but for health harming legal needs. So for example, for housing, if their landlord wasn't fixing mold in their home, they would go and advocate on behalf of the client. I mean, that's one of like many different examples, but I also am thinking in the policy realm. I think having lawyers at least be able to see what those policies are affecting in the home and bringing into long-term advocacy could be really helpful. But right now, what I've seen in a lot of different medical legal partnerships is more of that like first primary care stuff.
I love this. Thank you. And it's so, how did we not think of this? So we do see homes that are in need of repair that we want to advocate. And so typically what we've tried to do is like write letters to their reps, like the representatives or council persons in the city to try to push on landlords. But we're like professors in, I don't know, at Penn, but imagine if we had like a medical legal partnership who could help us in that way. I think that's so helpful. And to think about the policy. I've had people say, you need to hire someone or you need to work with someone who has policy expertise to help you push forward. You're like writing papers and all of this, but you really need to get this in front of policymakers. And we've fallen short of that. And I do think that you've just given me a really great idea about how to think differently about who to bring to the table with that level of expertise. So thank you.
Hello.
Hi.
So I'm a public policy student, and I was really interested in the idea of like scaling this type of service. So kind of similar to the last question. Mostly I was thinking about how like high income neighborhoods compare to like lower income neighborhoods, and how hospitals and maybe higher income areas don't experience like the same type of empathy overload, or I forget the term. And so I was wondering if you have thought about like expanding these types of services to areas that are higher income, and how you imagine that might look different.
That's such a great question. One, the scale and sustainability question is the thing that keeps me up at night. These grants come to an end, and I am constantly in meetings with our C-suite in the healthcare system to say, and they know it too, like we cannot let this go away. Like we have to keep it going. Healthcare systems, even ones that are more affluent, are like, we don't have any money. Like, so this is kind of the perennial challenge. So I'll just talk a little bit more about Penn. So the Penn has, I think, 7 or 8 hospitals now. And so Thrive is at all of the city hospitals, Pennsylvania Hospital, Hupp Cedar, Presby, and we're about to be at Hupp Maine. But there are a few hospitals in particular. So I'm thinking about Affluence. One is in Princeton and the other's in Chester. And then we have one in Lancaster, which is more rural. But Princeton Hospital, for example, has been really interested in bringing Thrive to Penn Princeton. Their Medicaid population is really, really low. And so we've been thinking, and we've kind of backed off it only just for time, but I say we'll circle back and thinking, how do we provide Thrive? And perhaps it's not to Medicaid, but they have other social vulnerabilities. And that's the adaptation. Because remember, our window has really been for Medicaid. But I think that we need to be a little bit more nimble because even though Princeton may not have a lot of Medicaid, they have other social challenges. And we have to be kind of thoughtful about how to identify who those pockets of people are and use their data to help tailor or adapt the intervention. So I don't believe that there are healthcare systems that don't have pockets of people who have social need. They may be unidentified, they may be flying under the radar, they may be getting the benefits of a spillover effect of being in just a great hospital for the time, but they still are probably going home with many of the same challenges that are unmet and unaddressed. I think the question about whether they experience empathy fatigue is a good one. I bet they do. I mean, one of the things we know, and probably because I'm involved in a hospital where several of the hospitals are magnet, nurses are still feeling burnt out. And so that burnout, even though better work environments are associated with less, I do think the experience of empathy fatigue or compassion fatigue is still there, but it may be operating for different reasons. And like I said, sometimes it's because of low resources, but even in high resource spaces, if you're not able to do the work that you feel compelled and passionate about, that too kind of leads to just a lack of kind of engagement, a kind of a low level apathy because you're just kind of like clocking in and clocking out. But the sustainability, like if you all have that solution, like that's the solution we need right now is thinking about like we have the evidence. How do you amplify it? How do you adapt it to different types of spaces and places? Who do you bring into partnership with you? Because I think that's really helpful. Speaking to Trevor, it was so interesting to think about how you have FTEs that are for social, like that communication is so important because a lot of times the researcher, you're trying to do everything. And so you're doing the research and the effectiveness, but amplifying it and getting it in the hands of the right people in innovative ways is really important.
Are there any other questions? We're close to our time, but could take one more perhaps.
I'd just like to first congratulate you on receiving the Edge Runners. For those who don't know, that is very high. So congratulations. And second, I just wanted to briefly, if you could touch on racism, because we know that, our profession, we are killing people because of racism. So is there any training for those that are serving this population, particularly because, they are low income, they are minoritized population. So just like to hear a little bit about that.
So we don't provide training on racism per se, but implicitly when I call out the way that we talk about patients in healthcare as being bounce back super utilizers or whatever, frequent flyers, like that is what racism looks like because they're talking about very specific people and they're not talking about other people in the same way. It's become acceptable, but by calling it out and saying you don't talk about your VIPs that way, but you talk about this segment. And this segment of your patient population looks a certain way. They are being discharged to communities that look away. And so we need to question and interrogate that. And so I think in working with our healthcare system partners and thinking about this as being systemic inequities and calling it out, but also calling people in and not necessarily saying you are being racist, but saying these systemic issues are a reflection of us as providers. And the ways in which we are providing care is unacceptable. But this is the way care has been. It's like almost expected. The fact that you call them frequent flyers, it means that you have anticipated they're coming back. There is no sense of urgency. Your hair is not on fire. Like, how is this acceptable that we are providing subadequate care to certain patients? And so that kind of interrogation, which is why I always talk about it when I talk about Thrive, is helpful, because if you're in healthcare, those terms are familiar to you. And if you've ever been a part of rounds when they use it, you know who's being talked about, but you also know that you care for VIPs that are not talked about in that way. They get high level care, they get private rooms, they get great food. Like, it's a different world, and that is in healthcare. It operates, if you're in a Medicaid only clinic or majority, the clinic doesn't look as pretty or as beautiful. It looks run down, it looks just okay. That's what racism looks like. It is palpable, you can see it, you can hear it, you can feel it. But how do we talk about it in a way so people feel like, oh, okay, I need to recalibrate, because I'm using this language thinking it's normative, and it is. It's become normative, and we've become desensitized to it. And we're training people up and saying, like, this is the way we talk. Oh yeah, they're a bounce back. Oh yeah, it's so casual. So casual and unacceptable and damning, right? And so I think your question is a good one about how do we train and what are our tactics that we use. And I'm careful because of where I work. I want to be able to bring students in a way where they don't feel like someone's calling them racist, because it kind of shuts you down. But really helping our students and ourselves to be open to blind spots that we might all have, right? And how do we acknowledge those blind spots? And how do we do the deep work of reflection? And it's a complicated dance, but it's one that I think is worthy of the question and thinking about how to go about it. So this is how I go about it, but I feel like there are many ways that one could employ to talk about openly discussing racism, particularly among healthcare providers, which is an open sore. And it's not just in nursing, it is an open sore. And we have to be really honest in that self-critique.
Well, thank you so much for this
you.
presentation and entertaining our questions. Let's thank again.
Thank you. You all were such a wonderful audience. Thank you for your questions and your community building with me. It was just such a pleasure to be here with you.
Thanks. Have a good week.
I'm working here now. They got you.